Okay, so let us now do congenital arrhythmias. So till now we saw the other type of arrhythmias. Now let us see the congenital. Okay, so we've seen till now the tachyarrhythmias, where in tachyarrhythmias we know that there was increase in the heart rate, and in bradyarrhythmias there was decrease in the heart rate. All right, so now we take look at congenital arrhythmias. Some of them are really important. So one thing that we will see is Brugada's syndrome. And what is affected over here is the sodium channel. All right, sodium channel. And that is why the sodium that comes in, the inward sodium current, that is reduced. The sodium that comes inside the cardiac cell, the inward sodium current is reduced. So if you look at the ECG, you will see that there are those leads like V1 to V3. What you will see over there is that there will be ST elevation, and whatever you saw in the right bundle branch block, that kind of a pattern you will be able to see. Now the importance of this is that this is one of the causes of sudden cardiac death. So usually you will find this in children, and in children you will find that the child is otherwise fine, and suddenly one fine day the child dies without any other reason. There is no asphyxia, etc. And so one of the important causes is Brugada's syndrome. The other cause that is there in this is long QT syndrome. These two things you have to keep in mind. Okay, long QT syndrome. Usually you will see it in children, and the typical history will be that this is a person, the child was otherwise all right, and suddenly one fine day the child was found dead in the crib, and there is no history of asphyxia. It is not as if the mother has by mistake slept over the child, or the child has been asphyxiated, the nose was pressed against the pillow or something like that. Nothing of that sort. Suddenly the child died. So these are two important differential diagnoses that you'll have to keep in mind. Now let us go to what is known as long QT syndrome. Okay, QT syndrome. Long Q means what? It is the beginning of the systole of the ventricle, and T is the beginning of the diastole. All right, this is the time. Now, what happens in this is that this is the time when the potassium channels are very active. So, what happens in these is that there is a mutation in these potassium channels, and that is why there is decreased potassium efflux in both of them. And as the name suggests, the QT interval, this interval will be increased in these people. Now there are three types. See, this is the Q1 mutation, then there is a KCNH2 mutation, and there is SCN5A mutation. Can you see? Here also it is SCN5A mutation. All right. And this caused decreased sodium current, whereas here you are going to see a persistent sodium influx. So over there, the sodium coming inside was decreased, but here the sodium coming inside is increased. So if you can see, the sudden cardiac death is associated with the same SCN5A type of mutations, okay, in both long QT type 3 as well as Brugada's syndrome. And both of them cause sudden death during sleep. So if a question comes where you see that the child has suddenly died in sleep without being asphyxiated, without being poisoned, think in terms of these two important arrhythmias. Both are associated with SCN5A mutation. Both are associated with problems of sodium. Both are associated with problems of sodium. All right. The first one is associated with decreased sodium coming in. The second one is associated with persistent sodium coming in. Okay. And apart from that, there are two other types of long QT syndrome, type 1 and type 2. And these are associated with potassium efflux. As the name suggests, all three of them will have a long QT or a prolonged QT interval. All right, of which 1 and 2 will present as torset the parties. What does that mean? Torset means turning. So you will see an ECG which is going in an upward direction, and suddenly you will have an ECG goes in the downward direction as if it has been twisted. Now, usually these torset the parties happen after drugs. Okay, there are certain drugs like erythromycin and cimetidine which cause these arrhythmias. But apart from that, in children, even long QT syndrome type 1 and type 2 can cause torsades, whereas long QT syndrome type 3, which is associated with sodium problem, is related to sudden death during the sleep. Then we have something which is related to calcium, okay, and that is called as catecholamine polymorphic ventricular tachycardia. So as the name suggests, it will have ventricular tachycardia when the catecholamines are active. Now, what are catecholamines? Epinephrine and norepinephrine. These are called as fight and flight hormones. When a person is scared, or when a person is some part of a battle, or if there is some kind of a danger. So here it is usually not danger, but an exercise induced ventricular tachycardia. So when the child has exercise, that is the time when that ventricular tachycardia is there, which means that the QRS complex is large, abnormal, and does not have any connection with the P. Okay, pure QRS complex is large, abnormal, and does not have any connection with P. Okay, so that is what is going to happen. Just give me a minute. Right, so that is what's going to happen. So that is important. Apart from that, there will be a short QT syndrome, which is exactly opposite. Now, why does that happen? There the potassium was not working properly in long QT. That is why the repolarization was slow, and that is why the QT was long. Here, the potassium channels are working very fast. So there is rapid repolarization. Okay, potassium channels have a gain of function, and that is why the QT is short. Now, what can this give rise to? This can give rise to multiple types of arrhythmias, whether it is ventricular tachycardia, ventricular fibrillation, or atrial fibrillation. Similarly, just as we saw atrioventricular blocks, similarly, there can be congenital atrioventricular blocks. Why? Because of developmental failure or conduction failure. All right. Now, AV blocks, as we know, are usually bradycardia. Remember, we did tachyarrhythmias, we did bradyarrhythmias. So AV block was bradycardia. Apart from that, there is something called as sick sinus syndrome. Now, what is important is that sick sinus syndrome is usually acquired causes, okay, like hyperthyroidism, etc., or hypothyroidism, etc. Sometimes, but sometimes they can even be congenital. Okay, what happens? SA node dysfunction. Usually, this gives rise to bradycardia. So, hypothyroidism. I'm sorry, not hyper. Okay, and it can give rise to syncope. And let us see what is happening in Brugada's syndrome. Brugada's syndrome, there is ventricular arrhythmias and sudden cardiac death. As I said, what is important for us? Sudden cardiac death. All right. And it is one of the most common mutations. This is the mutation that we talked about. This is important. And this mutation encodes the sodium channels, usually autosomal dominant. All right. So remember, this sodium channel causes phase 0 of ventricular action potential. Now, phase 0 of what? Phase 0, that is depolarization of the contractile tissue. The contractile tissue. This is the phase 0. This is the phase 1. This is the phase 2. This is the phase 3. This is the phase 4. Okay, that is what is happening. So this phase 0 or depolarization of the contractile tissue. Whereas in a conducting tissue, how does this happen? So this is because of calcium. This downward is because of potassium, and this is because of leaky sodium channels, which is called as fuzzy sodium channels. This phase 4 is because of leaky sodium channels. Phase 0 is because of calcium and phase 3 is because of potassium. This is in the conducting tissue. Remember, this is in the conducting tissue and this is in the contracting tissue, that is atria and ventricle. So here what is happening? Because there is rapid sodium influx, there is rapid depolarization. All right, rapid depolarization. Now what happens over here is when the sodium channels are not functioning properly, when that means sodium is not coming inside, there is reduced inward sodium current, and because of that the phase 0 is affected, and this gives rise to re-entry circuit. We know, right, that for this particular point of time, this is refractory period, this is absolutely refractory period, and this is relative refractory period. Now if this 0 itself is not straight, if it is going to take some time, what is going to happen? This refractory period is also going to extend. So if any such impulse comes during this particular time when the refractory period has not yet started, there will be extra impulse. All right, so that means there will be re-entry circuit, and this will give rise to extra contraction of the ventricles, giving rise to ventricular tachycardia or ventricular fibrillation, depending upon how much is the frequency. All right, so that is what is happening. So now what happens is that because of this, certain areas they depolarize differently, and this will give rise to ventricular fibrillation, just now as I told you. And ventricular fibrillation is a dangerous arrhythmia. Why? Because it's a job of the ventricle to contract properly. See, if the atrial fibrillation takes place, if the atria doesn't contract, what will happen? The ventricular filling will be less, but not very less, because we saw na, usually what happens, that atrial contraction, how much blood is given by atrial contraction, is less than the actual passive filling of the ventricles. So job of the atrium is not much. Atrial contraction gives only some amount of blood to the ventricle, whereas maximum blood comes from the passive filling. Remember, we had said, and when this is reversed, then we can say that there is some amount of diastolic dysfunction. You remember that when we talked about systolic dysfunction, we said that how do you measure systolic dysfunction? On an echocardiogram by left ventricular ejection fraction. But when this is reversed, which means that when atrial contraction gives most of the filling and when the passive filling is less, that means there is a diastolic dysfunction. That is what we had said, remember? So when atria is not contracting properly, if atrial fibrillation is there, it doesn't matter so much, because atrial contraction doesn't give rise to a lot of things. But on the other hand, if there is ventricular fibrillation, which means if the ventricle is not contracting properly, now what is going to happen? This ventricle has to really contract properly and give blood into the aorta. Now, if that is not happening, then the body is not getting blood, brain is not getting blood, even heart is not getting blood. And because of that, it can cause death. Because ventricular fibrillation doesn't mean that there is just one contraction extra or some amount of problem. There is a lot of problem. Ventricle is not at all contracting. So there is no blood inside the aorta. Right? This is what is going to happen. So ST elevation in V1, V3. Why? Because of abnormal repolarization in the right ventricular outflow. Similarly, there's going to be bundle branch like pattern. Why? Because there is a delayed activation of right ventricular region. Okay, that is what is going to happen. But this is not a true right bundle branch block. Okay, why? Because this is produced only by the sodium channel activity. The bundle is not blocked. It's just that the sodium channel is not working properly. And remember, nothing is happening to the conducting system. What is happening? It is to the contractile system. Depolarization, that is what is happening. So there will be ST cell elevation, which will look like shark fin. Shark fin ST elevation in V1, V3. And as I said, syncope will be there and sudden cardiac arrest or death can be there in the young adult, usually males. Sometimes there might be triggers like fever, alcohol, cocaine, sodium blocking drugs, large meals, etc. Okay, so they might give you these as one of the things. He had a lot of alcohol and then he was found dead, or he started on some sodium blocking drugs, etc. All right, that is okay. So if you can find out this thing, then you will give implantable defibrillator. Okay, implantable defibrillator you will put. Now, congenital long QT syndrome causes prolonged QT interval. Okay, and there is this turnabout. Okay, as I said, torsade de pointis will happen. All right, giving rise to sudden cardiac death. Now, what happens in this is that there is a mutation of the potassium channels or the sodium channels. Okay, so type 3 sodium channel, 1 and 2 is potassium channels. So there is delayed repolarization. Okay, and because of that, the QT is prolonged. Okay, QT indicates polarization. So that QT, that this wave that has to come down because of potassium, this wave is going to be prolonged like this because potassium channels are not working properly or the sodium channels are countering it. Okay, so as a result of which there is early after depolarization and torsades. Okay, so not only this, the depolarization that happens after that is going to be a little early. Why? Because it was supposed to be like this, no? But abhi kya ho gaya apna, दिस ये आराम आराम से हो रहा है। तो क्या हो रहा है कि ये पूरा नीचे जाने से पहले ही डिपोलराइजेशन चालू हो जाएगा। तो देयर इज अर्ली डिपोलराइजेशन एंड दिस कॉजेज अ ट्विस्ट। ओके, दिस कॉजेज अ ट्विस्ट इन द होल थिंग। Okay, this gives rise to a premature beat, and the various types, the features of the wave differ, and that is why it is polymorphic. Again, this can cause sudden death. Okay, it can cause sudden death. There are certain triggers like exercise and swimming. Sometimes they ask you about swimming. Okay, so this you must know. Similarly, the type 2, sudden loud noises can be a trigger, whereas in QT3, sleep. Okay, that is why they said na, the child was sleeping and died in sleep. Okay, no asphyxia but died in sleep. So what do? You usually start beta blockers. Okay, for these people beta blockers you have to start. So in the exam, if you see swimming induced syncope, think of type 1, Lloyd noise related type 2, and death during sleep type 3. Think about that. Okay, this is what it is. Now, in sixth sinus syndrome, what you get is dysfunction of SA node. So, SA node, which was contracting properly, starts contracting slowly, giving rise to bradycardia and sinus pauses. What do you mean by sinus pauses? Sinus means that it is originating, the beat is originating from the SA node. When the beat is originating from the SA node, we call it as sinus. When the beat is originating from the AV node, we call it junctional. When the beat is originating from the atrium, we call it as atrial. When the beat is originating from the ventricle, we call it as ventricular. So junctional arrhythmias, nodal arrhythmias, sinus arrhythmias, atrial arrhythmias, ventricular arrhythmias. Okay, so all these things, and these three together become supraventricular. These three things together become supraventricular. So if the sinus SA node is not functioning properly, most of the times there is bradycardia, but sometimes there might also be tachycardia. So it is also called as tachycardia bradycardia syndrome. Okay, so we know that just now only we revised, right, that what does the pacemaker activity depend upon? It depends upon the sodium leak, the potassium, and the calcium. So the depolarization of phase 0 is by calcium, phase 3 is by potassium, and phase 4 is by the leaky sodium channels. All right. So leaky sodium channels and calcium are the ones which are going to cause depolarization. All right. So if there is degeneration or fibrosis of the SA node, this automaticity, that means the ability to produce impulse, this decreases. Remember, if it goes lower than a particular limit, then what will happen? AV node will take over. If SA node fails, then AV node will take over. Why? Why? Because we said that the SA node is the pacemaker of the heart only because it generates impulse fastest. Okay, that is what. So there will be failure of impulse generation giving rise to bradycardia. Sometimes arrest might be there. All right. Usually it is age related, but it could be due to ischemia, cardiac surgery, drugs, diseases. Okay, that can also happen. So there is reduced SA node firing and sometimes cessation, temporary cessation or permanent cessation of the sinus. Okay, and sometimes there is a alteration between tachycardia and bradycardia. Right now, this usually presents with syncope or chakkarana. Why does that happen? Because if the pause of the sinus is long enough, the cardiac output will decrease. What is cardiac output? We know it is heart rate into stroke volume. Now, if this heart rate is decreasing, the cardiac output will also decrease. So that is why what will happen is, because the cardiac output is decreasing, the brain is receiving less blood. So cerebral hypoperfusion will be there. Okay, cerebral perfusion pressure is mean arterial pressure minus the uh, 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 intracranial pressure. Okay, minus the intracranial pressure. All right. Now, what is going to happen if the mean arterial pressure is going to decrease? Why will mean arterial pressure decrease? Because mean arterial pressure basically depends upon cardiac output into peripheral vascular resistance. All right. So if the cardiac output is low, mean arterial pressure will also be low. Now, if mean arterial pressure is low, then the cerebral perfusion pressure will also be low. So the brain is not receiving blood, and brain is not receiving blood, so there will be loss of consciousness. All right, that is important. So this is the reason, this equation is the reason why when you see a patient of trauma, you want to decrease the intracranial pressure. Why? Because and increase the mean arterial pressure. Remember, we had talked about something called a shock index. All right. So why we want the mean arterial pressure more? For the simple reason that if mean arterial pressure is decreasing and if the intracranial pressure is increasing, then the cerebral perfusion pressure will decrease and there will be hypoxia of the brain. All right. So this is what we don't want. All right. So if there is symptomatic bradycardia, you will want to put in a pacemaker. Okay, pacemaker. So pacemaker, what does it do? It supplements the SA node. So when the SA node is not functioning, the pacemaker will generate the rhythm. All right, that is important. If there is sinus bradycardia, the SA node response is normal. All right, when the block AV block, then that means the problem is below SA node, because this is SA node and this is AV node. If there is a block over here, then the problem is below this. All right, that is important. So this is just a summary of everything that we just saw. Now, let us go to a very quick revision on if you are in the USMLE examination and if you are asked a question on arrhythmia, then how do you diagnose arrhythmia? You've seen so many arrhythmias. Now you must be confused कि अभी मैं diagnose कैसा करूँ? पढ़ने को तो 20-30 arrhythmia पढ़ लिया, लेकिन diagnosis कैसा करना है? So let us see one by one the question. So the first thing that you will try to find out is that is it tachycardia or is it bradycardia? So normal heart rate is 80 to 100. So if it is less than 80, then it is bradycardia, and more than 100, that is tachycardia. All right. So that is, oh sorry, 80 to 100 नहीं, मैंने गलत बोला, 60 to 100. So 60 से कम है तो ब्राडिकार्डिया, 100 से ज्यादा है तो tachycardia. That is the first thing. Now you know whether you are dealing with the tachyarrhythmias or bradyarrhythmias. That two different algorithms. Okay. Now you are having tachyarrhythmia. Your patient has tachyarrhythmia. Now question is rhythm. Rate हो गया अपना, पहली चीज हमने क्या देखा, rate. दूसरा चीज हम लोग देखते हैं rhythm. How can the rhythm be? Is it regular or is it irregular? If it is irregular, is it regularly irregular? That means block hai. Yeah, is it irregularly irregular? All right. So that is what you should think about. Now, if you are looking at a regular tachycardia, there is a rhythm in that. You will think in terms of sinus tachycardia or re-entry or atrial flutter or ventricular tachycardia, okay, or WPW syndrome, right? This is what you will get. Now, if this is what you are dealing with, then you have to go to step 3. But if you are dealing with an irregularly irregular tachycardia, think of atrial fibrillation, multifocal atrial tachycardia, flutter with variable block or torsade. Now, in that case, you need to go to step 4. So, the first question you answered, rate is tachy. Second question you answered, rhythm is regular, and that is why you have come to this third step, in which they are asking you, is the QRS narrow or wide? QRS, is it narrow or wide? So if the QRS is narrow, all right, is there P wave before every QRS? If the answer is yes, then you are dealing with a sinus tachycardia. But you have a narrow QRS, okay, narrow QRS. So, if P wave is present, you are dealing with sinus tachycardia. But if the P wave is absent, then you are dealing with AV nodal arrhythmias, okay, arrhythmias of AV node. Now, are you dealing with sawtooth waves? If you are dealing with sawtooth waves, then you're probably dealing with atrial flutter. And when you're dealing with atrial flutter, that time the rate is going to be almost 150 or more. Now, if you are dealing with QRS complex, which is wide, question is, has he had a prior myocardial infarct? This person had a prior MI. If this is the case, then it is a ventricular tachycardia. Okay, then it is a ventricular tachycardia. Unless you prove something else, it is going to be ventricular tachycardia. But if this person has a delta wave, if this person has a delta wave, then you are probably dealing with a WPW syndrome. All right. So how did we reach this algorithm? Very simple. First, we found out rate, that was tachy. Then we said rhythm, that is regular. And because the rhythm was regular, we came to this third question, that is QRS. Is it narrow or is it wide? When it was narrow, then we saw the P wave. If it was present, sinus tachycardia, absent, AVNRT. And if the whole complex looked as if it was, P wave is like a sawtooth kind of appear, the whole thing is having a sawtooth appearance of the ECG, then it is atrial flutter. On the other hand, if the QRS was wide, then either you are dealing with ventricular tachycardia or WPW syndrome. Now, let us come. How did we come to this fourth question? Fourth question, first we said rate. Rate was tachycardia. Second question we asked was rhythm. Rhythm was irregular. So that is why we came to the fourth question. And fourth question was, are P waves present? Again, we are asking P waves, are they present? So if there are no P waves present, then you are probably dealing with atrial fibrillation. Okay, atrial fibrillation. But if you are dealing with P waves which are present, if P waves are present, now look at the morphology. Now look at the morphology. Okay, if there are three or more different kinds of P wave morphology, you are dealing with MAT. If you are dealing with a sawtooth like P waves, atrial flutter with variable block, and if it is twisting of the QRS complex, you are dealing with torsic pointes. Okay, so that is important. So three or more types, then you are dealing with MAT. If you are dealing with sawtooth flutter, then you are dealing with AF with block. And if you are dealing with QRS, variable QRS, then you are dealing with torsic points. Okay, that is important. All right. And you will also see whether there are any premature beats. So there is narrow QRS plus early beat. All right. So it could be premature atrial contraction, abnormal P wave, etc. Okay. Now you come to the bradyarrhythmias. Okay. So first thing we asked straight and we said bradyarrhythmias. So now what you will ask is there P wave before every QRS? If the answer is yes, now you will look at the PR. Okay, so yes, now you look at the PR interval. Is the PR interval more than 200 ms? If it is yes, then it is a first degree heart block. All right. Otherwise, if you are seeing a Mobitz type 1 progression, okay, progresses, and suddenly it gets dropped. Wenke-Bach's phenomenon, then it is type 2 second degree heart block, Mobitz type 1. If there is a fixed PR interval and then a drop beat, then you are dealing with a Mobitz type 2. And if there is no relation between P and QRS, you are dealing with a third degree heart block. If there is a wide QRS bradycardia, look at V1. Okay. So if you are seeing something like an RSR dash pattern, then it's a right bundle branch block. And if you see a deep S wave in V1, then you are dealing with a left bundle branch block. Okay, that is there. Now, what do you mean by RSR dash pattern? Okay, so the first downward deflection is Q. The first upward deflection is R. The second downward deflection is S. But suppose if there is another upward deflection, then it is called as R dash. R dash. Okay, so it will be like this. R, S, R dash. Okay, so this M kind of pattern, if you see, then you're dealing with a right bundle branch block, or if you're seeing a deep S over here, then you are dealing probably with a left bundle branch block. All right, so this is what you are going to see. Now let us go to pharmacology. Give me 1 minute. Okay, so now let us look at pharmacology. So what we are looking at is anti-arrhythmic drugs. That's the first thing. And who has given us the classification? There's a person called Vaughan William who has given classification. Now there are four classes of anti-arrhythmic drugs. Okay. So type 1 is sodium channel blockers. Type 2 are beta blockers. Type 3 are potassium channel blockers. And type 4 are calcium channel blockers, because these are basically the three things. Okay, so as you know, key in the contractile tissue, it's the sodium, calcium, potassium that works. Okay, whereas here there is calcium, potassium, sodium. Okay, this is phase 0, 0, 1, 2, 3, and this is 4. So 0, 3, 4. Beta blocker usually acts on phase 4. All right, sodium will act wherever sodium is supposed to act. Potassium will act where potassium is supposed to act. So let us uh, draw. Okay, so potassium will act slightly over here also, here also. Over here in the conducting tissue, potassium will act over here. Calcium will act over here in the plateau. Calcium will act over here. And if you see sodium, sodium will act here and sodium will act over here. Okay, sodium will act here. So there are, if you see the ECG, this is P, Q, R, S, and T. This is P, this is Q, this is R, this is S, and this is T. So what can be affected? See, this PR interval can be affected. This QRS complex can be affected, and this QT interval can be affected. These are the three things that are likely to be affected. These are the three intervals, okay, that are most likely to be affected. So let us see one by one what these drugs do. So as we said, type 1 are the sodium channel blockers. These are sodium channel blockers. 1A, 1B, and 1C. Now the question is that why do we have this 1A and 1B and 1C? Why? Because they have a different effect on the ECG. Okay, different effect on the ECG. Also, they have a different effect on the action potential duration. Okay, action potential duration. So the first one is going to increase the duration of action potential. Second one is going to decrease the duration of action potential. All right. So what is the first one going to do? It is going to increase the QT. The second one is going to decrease the QT. The third one has nothing to do with action potential, so it will not do anything to the QT. The first one has this, what do you say, moderate sodium channel block, so it will increase QRS. The second one has weak sodium channel block, so it will do nothing to the QRS. And the third one is marked block, so it will increase QRS. Okay, so if you see, okay, the type 1 will do nothing to the PR interval. It will either do to the QRS or QT. What is depending, QT dependent upon action potential, and what is QRS dependent upon? Sodium blockade. Okay, so 1A, which has a moderate sodium blockage, will cause an increase, and this increases the action potential, so it will increase the QT. 1B will have almost no blockage of the sodium as such, but it will decrease the action potential. And 1C will have no effect on the action potential, but it will have a marked increase in the sodium blockage. So QRS will increase. So their uses are also different. See, type 1B is used basically for ventricular arrhythmias. It has no sodium blockage. It is used for ventricular arrhythmias. Whereas the first and the last one are basically used for atrial ones. Okay, atrial ones. All right. A first ka side effect is torsades. It itself can cause torsades. Third ka side effect is that it is pro-arrhythmic. See, so the ones which are blocking sodium have their own arrhythmias that is there. Okay. Whereas type 1B has CNS toxicity. Now, if you go to beta blockers, what does it affect? It affects the stage 4 or the fourth part. Okay. So, as a result of which it will increase the PR interval. Similarly, calcium channel blockers will increase the PR interval. All right. It will not do anything else, but it will increase the PR interval, the calcium ones. The potassium channel blockers, they will also increase the QT. Okay, that means it will increase the action potential. So it will increase the QT. Why? Because it causes a lot of relaxation. All right, that is what can happen. Now, type 3, there can be torsad. The only one that doesn't cause is amiodarone. And remember, amiodarone is a very important one because it affects all the phases. Okay, all the phases. So it has basically action like everything. The calcium channel blockers mainly act on the AV node. Okay, mainly act on the AV node. Apart from that, there are certain miscellaneous ones which don't come in type 1, type 2, type 3, type 4. So, what are they? One of them is adenosine. This is very good for supraventricular tachycardias, AV non-reentrant tachycardias. Okay. So what do? Is they increase the efflux of potassium and they will transiently block the AV node. You see, now they are blocking the AV node, so that is why they are important for AV nodal arrhythmias. All right, AV nodal arrhythmias. Digoxin, what it will do? It will increase the tone of vagus, and it will, that is why the atrial fibrillation rate will be controlled. But the important thing about digoxin is that it causes yellow vision. Okay. Now, magnesium is another important one which stabilizes the myocardium. So this is used in torsades. So what is used in torsades? You have seen multiple drugs which are causing torsades, antiarrhythmics which are causing torsades. But which is it which is used for torsades? It is the magnesium. All right, magnesium. All right, atropine, which is muscarinic antagonist. Okay, and it is going to be used for bradycardia. Bradycardia, it is used for bradycardia. All right, if there is bradycardia, it will be used. See, parasympathetic, what does it do? It decreases the heart rate. So, if you have something which is going to see the parasympathetic has got muscarinic receptors and nicotinic receptors. So, muscarinic receptors are M1, M2, M3, M4, and M5, out of which 1, 2, 3 are important, out of which 2 is the one which acts on the heart. And if these receptors are stimulated, what will happen? The bradycardia will take place. Okay, that is decreased heart rate. So if you antagonize this with the help of atropine, what will happen? Bradycardia will reverse and it will become tachycardia. So it increases AV conduction. All right. So atropine may be used. This is very important in anesthesia. Why? Because in anesthesia, very often, sometimes it happens that the patient is in bradycardia. So then they give this drug to increase the heart rate. All right. Now, if you want to remember the names of the drugs, see, this is a mnemonic which they use in USMLE, double quarter pounder. So quinidine, procainamide, and disopyramide. So what is this double quarter pounder? Basically, in McDonald's in United States, this is the most popular burger that they have. Okay, so they remember it as double quarter pounder DQP. Okay, quinidine, procainamide, and disopyramide. All right, and what do? They increase the duration of action potential. So it is the first one. See, 1A. Okay, they increase the duration of action potential and moderate block of sodium. All right, lignocaine works best in ischemic myocardium. So usually when there is ventricular tachycardia or ventricular fibrillation after myocardial infarction, you use this. Okay, but if you use flecainide, which is 1C in patient of myocardial infarct, it can cause death. So please don't use 1C in a patient who has myocardial infarct. Okay. Yeah. So now we will take antihypertensive drugs. Just give me 1 second. Okay, so let's begin with antihypertensive drugs. Okay, so let us remember a very simple thing. Blood pressure is cardiac output into total peripheral resistance, all right, and which is equal to heart rate into stroke volume into total peripheral resistance. Okay. Similarly, cardiac output, basically, if you look at cardiac output, it depends upon three things. It depends upon number one, venous return. Venous return depends upon the volume in the veins and the caliber of the veins, or the diameter of the veins, or the tone of the veins, whatever you can call it. Then it depends upon the contractility of the heart muscle, and of course it depends upon the afterload. And afterload basically is one and the same. TPR and afterload is one and the same. Okay, so where all can we actually what do you say, have a control? We can control heart rate, we can control the venous volume, maybe caliber, usually the contractility and the afterload. Okay, 1, 2, 3, and 4, these are the common places, okay, which we can control. And that is how we can get the blood pressure under control. Okay, so let us see various anti-hypertensive drugs. So we start with an important drug called as ACE inhibitors. So we know that there is renin, and there is something called as angiotensinogen. So renin is produced by the juxtaglomerular cells of the kidney. And when will it be produced? When the blood supply to the kidney decreases. Angiotensinogen is produced by the liver, and this is converted into angiotensin 1, okay, with the help of renin. Now, angiotensin 1 goes to the lungs and is converted into angiotensin 2 by an enzyme called as angiotensin converting enzyme. Now, this is going to act on the angiotensin 2 receptors, and it will give rise to, or rather, it will stimulate aldosterone. And aldosterone, what does it cause? Aldosterone will cause the increased BP, it will cause alkalosis, it will cause increased sodium, and decreased potassium. All right. So ACE inhibitors, where do they work? They work on this angiotensin converting enzyme. So they will not allow angiotensin 1 to get converted to angiotensin 2. All right, and that is why they will stop this entire cycle. All right, and as a result of which the blood pressure will decrease. Now, why does the blood pressure over here increase? That is because there is a retention of fluid. Okay, aldosterone causes retention of fluid, so that is why volume increases, and this causes increased blood pressure. Okay, and also sodium is responsible for increased blood pressure. Now, if you block this axis, what will happen is that the aldosterone will not be secreted and the volume will not be increased. The tone, the total peripheral resistance will also not increase, okay, because this is also responsible for vasoconstriction. So vasoconstriction will not be there. This is the main mechanism. The vasoconstriction or afterload is the main mechanism by which this acts. Okay, so it decreases afterload quite a lot. All right, and this is what happens. So that is why ACE inhibitors are going to decrease the blood pressure. All right, which is the examples: enalapril and lisinopril. All right, usually used in hypertension, usually in patients with heart failure and diabetes mellitus. Now, what we need to remember is that this ACE is also a bradykininase. So since it is, if you inhibit this, it can cause cough. Okay, so it can cause chronic cough. Apart from that, it can also cause angioedema, which is an important side effect. All right, important side effect. Apart from that, what will happen is that this will also cause postural hypotension. postural hypotension. What do you mean by postural hypotension? The moment you rise, if you're sitting and you suddenly rise up, there will be giddiness. Okay. Why? Because it decreases the sympathetic tone. Okay, that is the reason. Now, instead of blocking angiotensin converting enzyme, and which is also a bradykinase, so instead of causing cough, what we can do is we can block these angiotensin 2 receptors. Ultimately, if we block these, then also aldosterone will be inhibited, right? So that is another way of doing it. So that is basically losartan or valsartan we can give. They are angiotensin receptor blockers. Okay, and the mechanism of action is similar. The use is similar as ACE inhibitors. All right, but the problem is that it can cause hyperkalemia. So one has to be careful. It can cause hyperkalemia, but it will not cause cough. Right? ACE inhibitors also protect kidney, especially in diabetes. Now, another thing is thiazide diuretics. So, how will diuretics work? Very simple. This volume part, it will decrease the volume because it causes a lot of diuresis. A lot of water will go, and the volume will decrease. Venous return will decrease. All right. So, that is what will happen. Now, exactly how does thiazide work? So, it blocks the sodium chloride transporter. So, this we will be studying a little bit in detail when we study diuretics with the renal system. Okay, that time I have a chart which I will tell you. So diuretics, especially thiazide. Thiazide, why do we use? Because it's a mild diuretic. You can even use furosemide, but furosemide is a strong diuretic. Furosemide causes a lot of hypokalemia compared to thiazides cause less hypokalemia. Okay, so as a result of which thiazides are more often used. Okay, hydrochlorothiazide, indapamide, or chlorthalidone. Okay, another important thing is that they increase calcium. They reduce excretion of calcium in urine. So because they are blocking this transporter, they help the calcium to go in, okay, through the cells. So they cause more and more absorption of calcium into the blood, and less calcium goes into the urine. Why is this important? This is important because in people who have got recurrent renal stones, you can give thiazide diuretics so that the calcium does not go into the urine and cause stones. Okay, that is one thing that you can do. Then there are calcium channel blockers. Okay, so as the name suggests, calcium channel blockers, what will it do? It will cause dilatation of the blood vessels, vasodilatation. Especially where will it cause vasodilatation? Usually in the total, causing decreased total peripheral resistance. So because of that, because the total peripheral resistance decreases, what will happen is that it is used basically in hypertension to decrease the blood pressure. Now, what is the problem that can happen? It causes a lot of edema. People who have anti-hyper and these calcium channel blockers, they will have a lot of pedal edema. And apart from that, it can also cause reflex tachycardia. Okay, reflex tachycardia. Okay, so some of the beta blockers, what do they do? Have you seen beta blockers? No. Beta blockers, especially, see, if you see the adrenal receptors, there are alpha receptors and there are beta receptors. Alpha has alpha 1 receptor, alpha 2 receptor. Beta is beta 1, beta 2, and beta 3. Now, out of this, alpha 1 causes vasoconstriction. So at present, I'm only talking about what effect it has on blood pressure. Alpha 2 is antagonist of the adrenal. Okay, so what it does is that it goes to the preganglionic region and it blocks the ganglion. Okay, it blocks the ganglion. So effects do not take place. Effects of adrenal do not take place. So alpha 2 is like anti-adrenal. Beta 1 causes increase in the heart rate, tachycardia. So if you give beta 1 blocker, what will happen is that it will decrease the heart rate and that's why it will decrease the blood pressure also. See, can you see over here? Heart rate is one of the components of blood pressure. So it will decrease the blood pressure. So we can give metoprolol, atenolol, they will all decrease the blood pressure. In fact, metoprolol has a good effect in myocardial infarction also, after myocardial infarction, to gain the strength of the muscle. All right. Propranolol is non-selective. It is not only alpha, only beta, both. Okay. So that is there, and you can use this in hyperthyroidism because it gives good effect. Okay, even in migraine. Carvedilol is alpha plus beta blocker. Okay, this is basically used when there is pheochromocytoma. Even labetalol. Okay, beta and alpha blocker. Now, labetalol importance is that it is used in pregnancy. Okay, labetalol is good to use in pregnancy induced hypertension. Apart from that, as I said, you can give alpha blockers also, especially alpha 1 blockers. All right. So, what will you give? Earlier, there were non selective ones like prazosin. Now, the problem with prazosin is that it has got something called as first dose hypotension, which means that because there is no vasoconstriction, because there is vasodilatation, what is happening is that suddenly the blood pressure goes down. When the person has this first dose of has this dose of prazosin, suddenly the blood pressure goes down and the person feels giddy. So usually we are supposed to give this at night. Okay, because it causes dizziness. Okay, at night you are supposed to give this. Okay, now what are the drugs that you use for hypertensive emergencies? You can use nitroprusside. Nitroprusside usually causes venodilatation. All right. Apart from that, nicardipine is also calcium channel blocker. Clevidipine, you can use labetalol, you can use in pregnancy. Hydralazine, you can use in pregnancy. Hydralazine is also arterial dilator. Okay, dilator, vasodilator. So it decreases the uh, uh, decreases the Now, in heart failure, which drugs you can use? So you can use in heart failure. See, you want to reduce the load on the heart. So you can use diuretics. Okay, these are the diuretics you can use. Furosemide is a very potent diuretic. Again, as I said, furosemide we will study when we study renal system. It is basically sodium chloride and sodium potassium and 2 chloride transporter which it blocks. Okay, that is one thing. Torsamide, butamide, these are all those class of drugs, loop diuretics as they are called it as. Okay, thick ascending limb. They work on the thick ascending limb. TAL. Then digoxin, what does it do? It's an ionotrope. Okay, it's an ionotrope. See, as we said over here, digoxin is an ionotrope. So it increases the contractility. How? As I said, it blocks the sodium potassium ATPase. So what happens is because it blocks sodium potassium ATPase, what is the job of the sodium potassium ATPase? To send sodium outside. Okay, and when sodium goes outside, what happens is that calcium starts coming inside. And when more and more calcium is there inside the cell, what will happen is that because of that, the contractility will be more. So when this, so what happens is sodium, potassium, ATPase, sodium is thrown out. And when sodium is thrown out, along with that, calcium is also getting thrown out. Okay, that is what is happening. So now, when this sodium, potassium, ATPase pump is being blocked, what happens is sodium does not leave the cell. And because sodium does not leave the cell, what happens is calcium is also not thrown out. And because the calcium is not thrown out, what happens? There is more calcium inside the cell and it causes contraction. Similarly, milrinone, it is inhibitor of phosphodiesterase 3. What does this do? This inhibits the CAMP. Okay, because of that, what will happen is that there is increased calcium in the cell. Because it inhibits, there's increased calcium in the cell, and because of that, what is going to happen is that the cell is going to contract much better. Similarly, dobutamine is a beta 1 agonist, and it causes the cell to contract better. So as I said, sodium potassium ATPase inhibitor increases the intracellular calcium causing contractility. But the problem with digoxin is that it can cause yellow vision. Okay, it can even cause some arrhythmias and hyperkalemia. Okay, so that might be one of the things that can happen. Now, what are the drugs used in myocardial infarction? You just need to remember this, okay? Morphine can be used for pain, oxygen, nitroglycerin causes venodilatation, aspirin, beta blockers can be used, ACE inhibitors can be used, statins can be used. This is for the cholesterol part of it, LDL cholesterol. Heparin and clopidogrel, blood thinners. Okay, heparin and clopidogrel, blood thinners. So, which are the drugs that reduce mortality? See, all of these drugs can be used. They have various functions, but out of these, which are the ones which will reduce mortality? Aspirin, P2Y12 inhibitors, beta blockers, ACE inhibitors, and statin. Okay, so these are the ones which are going to decrease. So in your USMLE, once in a while they might ask you which is the one which is going to decrease mortality. Okay, so remember aspirin, remember beta blocker, remember ACE inhibitor. These are the three ones which are usually asked. All right. So apart from that, when there is myocardial infarction, you can give alteplase, this ritaplase, etc., so that it causes thrombolysis, and preferably you need to do an angioplasty. Okay. So what does alteplase do? It converts plasminogen into plasmin, whereas these two are recombinant TPA. Okay, modified TPA that is there. When will you not do fibrinolysis? This is again important because sometimes it can be asked in the exam. So if there is a previous hemorrhagic stroke or the person is actively bleeding, they tell you that 2 days ago he had an episode of hematemesis and now he's got myocardial infarct. Don't give. If they are saying that this person has had an aortic dissection recently or recent brain surgery, okay, then don't give. This is important. This they can ask sometimes. Okay, that is one thing. These are blood thinners. We will be studying blood thinners more with hematological system. Okay, so just remember aspirin is a COX inhibitor, cyclooxygenase inhibitor, whereas these three, clopidogrel, prasugrel, and ticagrelor, are P2Y12 inhibitors. Okay, these increase the survival after. Okay, this increases the survival after myocardial infarction. There are other anticoagulants. All these anticoagulants basically we will be studying when we study the uh, and this hematological system. Okay, so this was about your what do you say remaining part of cardiac pathology. Okay, thank you.